Welcome to the Heart of Innovation. 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hey everyone, welcome to the show. What do we do about chronic pain? The opioid crisis is limiting critical pain relief for patients who need it in order to protect those who are abusing it. It's a really big problem for those who just can't seem to get any relief. I know that I deal with it on a daily basis with patients who have peripheral artery disease, which is restricted blood flow in mainly the leg arteries due to plaque buildup. And these patients report it feels like a tourniquet wrapped around their legs 24/7. Imagine trying to walk, trying to sleep with this tourniquet wrapped around your legs. But there's no relief in sight, especially if they end up with neuropathy because they waited too long to get their blood flow restored to their feet. With us today, we have someone who may have a solution that he and his team are working on, though, so maybe there is some hope. Vladimir Yarov-Yarovoy, professor of physiology at University of California, Davis, is joining us to talk about a new study he's working on. Dr. Phillips, you know just as well as I do, because as an interventional cardiologist treating patients with PAD and other vascular disorders, pain relief is needed.
Exactly, Kim, and happy Saturday, right? Another week has come
and today's Red Sock Day for peripheral artery disease awareness.
That's awesome. Yes, I have my socks ready to wear. But no, this is going to be a fantastic and enlightened show. I've been looking forward to speaking with Vladimir for quite some time since I've been researching what he's been doing, because you not only have people who have chronic pain, but you also have people that have become addicted to the pain medications, right, and senseless deaths from overdose. So obviously, the research is groundbreaking. It's going to take years to develop, I imagine, but we have to figure out a way to help these folks aside from just, giving them pills that mask the pain and that can also lead to addiction.
That's definitely critical. So I think we should jump right into the conversation. But first, a moment of inspiration.
Dr. John Phillips' spectacular vascular moment of inspiration.
Well, I'm going to give you a quote from William Osler, the father of modern medicine, who basically revolutionized the way medical education was taught. He was at Johns Hopkins School of Medicine. And I like this quote. He said, "A good physician treats the disease. The great physician treats the patient who has the disease." And I think that's the heart of what researchers like Vladimir are doing. It's trying to get personalized medicine to these folks. So let's get on with the show.
Yeah, I agree. Vladimir, what do you think? That's a pretty appropriate quote for this show as we get started.
Absolutely. First of all, thank you so much for inviting me, for the opportunity to talk about our research. And absolutely, the precision medicine, as we call it, focused on individual patient needs. This is the future where we are going with our approaches and our team here at University of California, Davis School of Medicine. What we are trying to achieve with our team is to develop new alternatives for therapeutics to treat chronic pain, and specifically working on a subset of peptides and antibodies as potential replacements for opioids to treat chronic pain. And the idea is that we have, yes, please.
When it comes to pain, and I think it's really good to clarify, First and foremost, you do want to get to the root cause of the pain, right? See if there's a way in which, for example, with peripheral artery disease patients, you want to make sure, has the blood flow been attempted to be restored? In other cases, there might be other things that are going on to ensure that that we understand and we can treat what's causing it versus putting a Band-Aid over it. And sometimes when you're talking about pain medications, such as opioids or anything you might be working on, that's more of a Band-Aid, especially when, they can't do anything more. They need something in the meantime, correct?
That's correct. Absolutely. But we basically designing alternatives to opioids that would be safe and effective. And this is where peptides that we're designing right now and antibodies that we started to work on more recently would be very effective in our view, because they will be interacting with the key receptors that are transmitting pain signals very potently and very specifically. And specificity is, yes, please.
No, I'm sorry to interrupt. I was just, I was curious as I was reading about your research, like, how did you get into this particular thought process of using monoclonal antibodies? Where you're a professor of physiology.
That's right.
Do you do a lot of basic science research, and then ultimately?
Yes, indeed. But this is where the ideas for both antibody development and also peptide design that we have came originally from my work at the University of Washington in Seattle. Before I came to Davis, I spent a number of years at the University of Washington working on voltage-gated sodium channels, which are key transmitters of pain signals in peripheral nervous system. And so I was aware of their key role in transmitting of peripheral pain sensation signals for many, many years.
Okay.
And when I moved to UC Davis, I realized that we need to undertake this challenge and develop very selective and effective therapeutics to treat chronic pain. And at the time, that was about 12 years ago now, I approached clinicians at UC Davis pain clinic, Dr. Koppenhaver, Dr. Fishman, and we had, big discussion about how we, basic science researchers, can actually come up with therapeutics that would be useful for them as physicians in clinic and ultimately will help patients with chronic pain. And at the time, there was no big investment from National Institute of Health and ultimately from the government available to pursue these new ideas that we've been brainstorming. However, it all changed back a few years ago when NIH created this so-called HEAL initiative, which stands for Helping to End Addiction Long-Term Initiative, and invested $1 billion. That was initial investment from Congress to focus on development of new therapeutics to treat pain and also to ultimately help people with addiction to opioids.
Bring us back to the conversation that you were having right out of the gate when you went to your fellow professors and said, hey, I have this idea. What was the response at that point? Did you feel that there was resistance, or were they with open arms? A lot of times when you deal with other professors, you always get a little wall up initially with a healthy dose of skepticism.
Oh, actually, they were also excited about the opportunity that we have at the basic science level to pursue this research that can make actual impact in the clinical practice and hopefully help patients. But the key missing component was investment into this new, more risky research, which basically the ideas that we had were very new in this field of ion channel pharmacology and physiology. And also at the time, we didn't have very high accuracy structures that we need to perform more accurate computational design. And I'm talking about structures of actual receptors, actual proteins, which are basically ion channels, specifically voltage-gated sodium channels that are involved in transmission of these pain signals. So
we'll come right here on the part of innovation. I'm going to have Vladimir get a little bit more layman on some of that explanation, because I'm not a scientist. I don't know about you. So stay tuned. You're going to want to learn more, so stay with us.
Leg health can indicate risk for heart attack, stroke, and amputation. If you have leg pain or cramps while walking, get checked for peripheral artery disease, or PAD. PAD is plaque buildup in mainly the leg arteries. Be sure to ask your physician for an ankle brachial index, also called an ABI test, where they use blood pressure cuffs to analyze the blood pressure in your legs. If they discover you have arterial plaque that's limiting blood flow to your feet, medicine and a regimented walking program are frontline treatment. If PAD is in its advanced stages, your physician may schedule a surgical intervention. Minimally invasive tools are available to remove plaque and restore blood flow, including Cardiovascular System's Diamondback 360 atherectomy system, which sands away plaque that is a hard calcium. It's important to discuss all options with your physician, and if told you have no options, get a second opinion. Take a stand against amputation. For more information, go to standagainsamputation.com. That's standagainsamputation.com.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We are continuing our fascinating conversation with Dr. Yarov-Yarovoy, who is trying to develop very specific ways to treat pain in folks that have chronic pain that is not a pill form. And during the break, we were just kind of talking about what the inspiration was. And I said, as a clinician, all advances in medicine start with basic science. Folks smarter than me developing, whether it's a new piece of technology or a pill, or in this case, these antibodies. And so, Vladimir, continue your story. Yeah, you got inspired by meeting with fellow clinicians who treat folks with chronic pain. Now you've got this idea. All right, how do you get it across the finish line?
Yes, absolutely. Because ultimately there have been multiple sources of inspiration for this research and for our original idea. Some of my family members, close and distant, suffer from chronic pain. Some of my close friends, also some of my colleagues in the scientific community and beyond. And so this is where I have, personal, basically, inspiration from all these people to try to make impact in their life in the future. And also, when I visited clinic here at UC Davis Pain Clinic, they allowed me to shuttle patients. And basically, I've seen how they do procedures, how they talk to patients. And I remember one of the moments when a patient walked in their office and he told one of the physicians, "I just want my life back."
Yeah.
And those simple words really provide, very deep inspiration for our research as well. Because
so you're sitting there, 12 years ago, and you had this idea, you talked to your colleagues, and you didn't have the funding available at the time that you needed in order to make this happen. That sort of quote from a patient can be very powerful and help keep you fighting until you can remove those barriers to moving forward with research like this, right?
That's absolutely the story that we had, Kim, actually, because ultimately we had to wait a number of years till funding became available at the scale that we needed, and also to be able to pursue these more risky ideas. And ultimately it all converged in early 2019 when NIH established that HEAL initiative, finding opportunity. We had new computational methods recently developed at the time available, and also structures of our key receptors at high resolution became available. So sometimes in life, timing is crucial to be able to make further progress. And this was the time when it all changed for our team in early 2019.
For those of us who are not scientists, can you break down that whole idea of these structures for these receptors? Because that's a little over my head.
Yes, absolutely. So basically,
mine too.
Yes, absolutely. We are able to see the actual atomic resolution structures of proteins that we're not able to see with our eyes, because they basically at nanoscale. And there are methods that recently been developed. One of the teams actually at the University of California, San Francisco, contributed to a recent revolution of cryo-electron microscopy. And some of the structures we're using for our research have been solved by this new technology that able to capture proteins at atomic resolution. And we need that information, that data, to be able to more precisely design new proteins and antibodies to interact with these key receptors.
So, Vladimir, is it kind of a lock and key theory?
Precisely. Okay. But you need to know the lock, basically, structure, right, to be able to design the key. What's been happening for many, many years, for now decades, that industry have been trying to design new, very selective and safe therapeutics to treat pain, and they failed for many, many years. Why? Because they've been trying to basically do this design blindly without knowing the structure of the actual lock. In this case, the lock is actually voltage-gated sodium channel that we need to stabilize in a closed conformation so that it will not be transmitting pain signals in patients with chronic pain. That's a key challenge at the level of basically protein structure.
So the breakthrough, I guess in your mind, the breakthrough for this idea, was it the ability to use computer software and these electron microscopes to actually visualize the lock?
Yes. So having those structures, which actually been solved by our neighbors here in San Francisco at Genentech, they solved that complex of the sodium channel with one of the peptides bound. And we used that structure, which became available in early 2019, to perform the computational protein design. And for computational protein design, we're using software from my former mentor's lab at the University of Washington, David Baker, in the Department of Biochemistry. So his lab developed software called Rosetta. You may have heard, of course, about Rosetta Stone, Rosetta software for language learning. This is a Rosetta software for protein modeling and protein design.
Oh, wow.
And more recent versions of this software are now taking advantage of artificial intelligence, specifically deep learning methods, to come up with even more accurate protein designs. So this is where the timing, again, is so important. So having the structure of that basically lock, right, is the key, and having more advanced methods to design these peptides more accurately. So peptides you can think about as a key, and antibody as a key to basically lock the channel in specific conformation that will prevent it from opening.
I love the fact that you were saying, okay, timing is everything, because if you would have gotten this big grant to pursue this research 12 years ago, you likely would still be where you're at today, and maybe without money at this point. Right? Because you would have exhausted all these, almost felt like you were spinning your wheels. And I think it's important for patients to know, gosh, it's always an evolution, right? Yes. To get to the next level, to get to the next level, to get to the next level. There are these stepping stones. So basically, where are you at today in development?
Yes, so basically we recently actually reported on our progress in the publication in the eLife journal. And in this publication, we summarized our progress to date on peptide design part of the project, where we've been able to come up with more selective and still very potent peptides interacting with the key sodium channel involved in transmission of pain signals. And we made it much more selective than any other available peptides basically created by both academia and industry to date. However, there's still room for improvement. We still see the opportunity that we can make it even more selective. And why selectivity is such an important consideration, ultimately it's related for patient safety. That means we want to minimize potential side effects of these peptide-based therapeutics in the future. And so we need to improve the selectivity even further. And we know
That's a really interesting point, and I want to follow up with that after the break. We're going to jump off for a moment here on the Heart of Innovation. We're going to get back to Vladimir because I am curious. I think that that's a big point to make when you're developing a medicine. How do you reduce the side effects? So we're going to have him explain that coming up next, so stay with us.
3 years ago, my symptoms started with leg pain and leg cramps while walking.
Me too, with a tightness in my calves.
Well, do you know, my doctor thought that my leg cramps were a side effect of the statin he prescribed me.
Well, my doctor just brushed them off as another symptom of old age.
Mine thought the pain was radiating from my spine.
My doctor blamed my neuropathy on diabetes until I got a wound on my foot that just wouldn't heal.
Yeah, it turns out we all have peripheral artery disease, also known as PAD.
It's plaque buildup mainly in the leg arteries causing poor circulation.
For me, the diagnosis came too late and I lost my leg, but that does not have to happen to you.
No, it does not, because there are treatment options available if you're diagnosed early enough.
PAD, peripheral artery disease. If you've been experiencing leg pain, leg cramps, or neuropathy when walking, and your doctor isn't hearing you, we are. We are The Way to My Heart, the largest support network for peripheral artery disease patients, and we want to help you get back on your feet again. Visit our website at thewaytomyheart.org or call our Leg Saver hotline, 415-320-7138. Your life and limb could depend on it.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
So before we went to break, Vladimir, you shared with us where you guys are to date, and this was published eLife Sciences, and we'll post the link on the blog. But how many, you're working on peptides and you're working on antibodies too. So two different types of proteins that hopefully both will be the key, right?
Yes.
But they have to be very specific because obviously we're trying to mitigate side effects. Absolutely. So today, it's February 2023. Walk us, in your mind, best guess, like how long is it going to take to get these peptides where you need to be, get the protein antibodies where you need to be, and then maybe do some animal testing and then human testing? And because there are people listening right now that are probably like, oh yeah, I'll take some of this today.
That's right. But this is where we see opportunity to improve the specificity of our peptides over the next couple of years to the level where we can actually go to clinical trials. And the first opportunity would be to do the clinical trials using so-called intrathecal injection. This is where peptides will be delivered in the spinal cord region, close to the peripheral nervous basically system.
So this would be something almost like a cortisone shot where you have to go into twilight and, you get the IV, you have to go into a twilight type of sedation and have that injected.
Well, basically in the spinal cord region, right, this is where sort of direct delivery to the dorsal neurons that actually have these voltage-gated sodium channels expressed. And we need to silence those neurons' activity in patients with chronic pain. This is the first potential route of administration. The second would be IV. This is where we also will be working on versions of our peptides that will be delivered using IV administration. Yet another alternative approach would be to develop peptides that actually can be taken orally as a pill, or as basically administered through intranasal administration as a nasal spray.
Really?
This is where we're going to be having
a pain medication delivered that way.
Yes, so this is where we're going to have alternatives going forward to the routes of administration, and we will see for different patients with specific pain conditions which routes of administration will be most effective and safe, right? Because that's definitely the key to have more effective and safe pain relief, right? This is working on peptide design. We're talking about at least 2 years of more basic science before we go into clinical trials. And then clinical trials will take, at least 2 or 3 years to show the potential efficacy in patients.
What do you think the biggest hurdle is going to be in the next couple of years to get to that point where you say, okay, we're ready for clinical study?
Yes, so this is where we need to actually design and test as many more of these variants as possible. And right now the limitation is basically funding. So we're applying for new funding to continue optimizing these peptides. And we hope to get maybe 2 new grants this year to pursue this research. But this will depend how much funding we will have to test new, more optimized variants of these peptides. Because the more we test, the better chances are that we can come up with more optimized and more selective and ultimately safe peptide for clinical testing.
So you mentioned peptides as one key.
Yes.
And then antibodies are another key?
Exactly, because antibody, that's a new project that we got funding for from the same NIH HEAL initiative last year. Mm-hmm. And so this project basically is our second alternative branch of efforts to develop therapeutics to treat chronic pain. And why antibodies are different compared to the peptides, ultimately antibodies are also proteins.
Okay.
And basically they are generated by our immune system response. But we are using this idea of developing antibodies as specific keys for the same receptors. And the difference between peptides and antibodies are size. Antibodies are bigger, even though there are different sizes that we explore of antibodies as well. And with antibody in the future, we can potentially have more sustained pain relief because they can be injected subcutaneously and get in the circulation and last in circulation for weeks. With single injection of antibodies in the future, we see opportunity for patients with chronic pain to have sustained pain relief lasting for more than a month.
Now explain where you got the idea for these monoclonal antibodies. I heard that they had been involved in cancer research and treatment.
Yes, indeed. I mean, the original idea actually came from protein structure for us because there've been protein structure solved with one of another ion channels in complex with antibody. And that structure provided inspiration to come up with antibodies that would be also interact with our key receptor, voltage-gated sodium channel, in a similar way. And so this is where, from structural perspective, we already seen opportunity that antibodies can bind like a key to a lock,
right?
Very specifically.
Now, if you had your choice, or maybe you need both, so let me ask you this way. Do you need peptides and antibodies, or is one going to be better than the other, and you just don't know yet?
We don't know yet. Certain patients may prefer antibodies for more sustained pain relief. Others may prefer daily pill, or maybe the pill would last a few days, just a pain relief. That's also possible. Some may prefer IV administration as another alternative. But this is where we want to give patients opportunity in the future to select from these multiple different options. And for some patients with specific pain conditions, they may choose one versus another. Having those alternatives in the portfolio of potential treatments for patients, that's essential. Again, coming back to the, precision medicine related future. This is where patients would be able to choose more effective treatments that works for them.
So more choice for pain relief is on the way, coming up right here on the Heart of Innovation. We're going to find out just how close we are on one versus another. I know clinical trials may be a couple years out, but we're going to get a better idea on the timeline coming up next. You don't want to miss it, so stay with us. If you have blocked arteries, and mainly the leg arteries, known as peripheral artery disease, you will breathe much easier if you stop smoking. I'll tell you why. Hi, I'm Kym McNicholas, CEO of thewaytomyheart.org, with this week's medical notepad brought to you by Cardiovascular System Incorporated's patient advocacy campaign, Take a Stand Against Amputation, and The Way to My Heart. Did you know there are thousands of harmful chemicals in each cigarette that enter into your bloodstream with every puff? Your heart pumps blood into the lungs to gather oxygen, which is then distributed throughout your body. One such chemical is carbon monoxide. When carbon monoxide is present in the bloodstream, it binds to hemoglobin, preferentially over oxygen. As a result, oxygen cannot bind to the hemoglobin in the red blood cells, so very little oxygen is transported throughout the body. A pack-a-day smoker can have a 3% to 6% carbon monoxide level in the blood. Smoking 2 packs a day, the level may be 6% to 10%. In a 3-pack-a-day smoker, carbon monoxide levels may reach 20%. Normally, someone has 0 carbon monoxide in the bloodstream. Lack of oxygen in cells forces the heart to work so much harder to distribute oxygen around the body. The moment you quit smoking, the level of carbon monoxide in your body will return to normal within 12 hours, meaning your heart won't have to pump as hard to distribute oxygen. If you're trying to quit smoking, here are 5 steps that might help. Step 1, make a firm commitment saying, I desire to quit. Step 2, identify the triggers which cause you to reach for another, which will help you to decide whether stopping cold turkey, using a patch, reading a book about how to quit smoking, joining a support group, hiring an addiction counselor, or watching a webinar will be effective for you. Step 3, find something to do with your fingers or your hands, such as a rubber band or pen to twirl, or have a bag of a portioned mix of nuts, dried wasabi peas, even sunflower seeds handy. Step 4, just don't kick yourself for lighting up. That's a bad thing. That negative reaction can cause you more stress and anxiety, leading to even more puffs. Instead, remind yourself that it's okay to be where you are in this journey and that you maintain your commitment to quitting. Remember, I desire to quit. Keep that in mind at all times. Step 5, surround yourself with friends who will support you, not shame you. Stress, again, is one of the leading triggers to light up. Now, here's a bonus. Several patients with PAD in the Way to My Heart's network are talking about a technique that seems to work for them. Light up 1 cigarette and only take a few puffs until you feel satisfied. Then extinguish it. The next time you have a craving, pick up that same cigarette and take a few more puffs. They say after a few days, you'll realize that you are consuming far fewer cigarettes than before. And over time, your goal should be to get to the point where not even 1 puff is needed. With this week's medical notepad, I'm Kym McNicholas, CEO of thewaytomyheart.org. If you need support from fellow patients trying to quit smoking, download the Way to My Heart's Peripheral Artery Disease app on Google Play or from the App Store on iPhones. Search Peripheral Artery Disease, and I guarantee you'll find it. For more information on peripheral artery disease, go to standagainsamputation.com. And remember, the advice and views offered in this series are for educational purposes only. Always check with your own healthcare team before acting on any advice offered here to ensure it's appropriate for you.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. We are continuing our fascinating conversation with Vladimir regarding innovative ways to treat chronic pain. And during the break, we were just kind of chatting about, or at least I was asking you, Vladimir, what are some concerns that you have about developing peptides and antibodies? So specifically, big time, what side effects do you worry about? Obviously, as you're trying to get very specific and make that key fit that lock as precisely as you can, there's going to be some hurdles that you guys run into. What are your thoughts on that?
Yes, happy to discuss. With respect to our peptide design and development, we've been able to improve the selectivity for our key receptors, sodium channels expressed in the peripheral nervous system, versus sodium channels that are expressed in the heart, in the brain, and skeletal muscle. So this is where we already see that there shouldn't be side effects of our peptides in the future clinical trials.
Wow.
They should not affect the activity of sodium channels in the brain, heart, and skeletal muscle. However, we do still need to improve selectivity versus sodium channels expressed in neurons that are responsible for motor function. So peptides will be developed. They have limited selectivity versus sodium channels expressed in motor neurons. But clearly, we already see that we need to improve the selectivity even further so that we are not affecting the motor function of patients in the future. So
I think that's an interesting point, because I always wonder with medications and as they're being developed, how do you make sure that the medication is only focused on this one particular area and doesn't affect other areas? And I'd love for you to go into a little further explanation on that, maybe in a little more layman's terms, because I find that incredibly fascinating.
Yeah, absolutely. Because this is where we have, multiple basically keys in terms of the actual sodium channels expressed in different tissues. I mentioned heart, brain, skeletal muscle, and motor neurons, right? So we want to only design peptides that fit into the lock, ultimately, of the peripheral nervous system, responsible for transmission of pain signals, and not affect any other locks, and not affect any other tissues that are important for our physiological function. And that's been the key challenge for therapeutic development in general, but for the pain therapeutic in particular, because there have been a number of clinical trials over the past 10 years or so of different compounds developed by Pfizer, Genentech, and others. And those were small molecule-based, basically, compounds in clinical trials. And unfortunately, all of them have not been able to pass the clinical trials. Why? Because of toxicity. They did have side effects on other sodium channels and other proteins. And ultimately, this is the key challenge in development of safe therapeutics. And we see right now, based on our data that we published and some of the new data that's not published yet, we have opportunity to actually enable very high precision selectivity of only targeting sodium channels involved in transmission of pain signals and not affecting any other sodium channels.
So let's jump ahead into the future, and let's assume you have some peptides, antibodies that work, and now they are available to patients. Part of this HEAL initiative, from which you got your grant, was to reduce and help eliminate addiction. Do you feel like, number one, you can do that, but conversely, could these antibodies or peptides cause addiction too?
Very important questions. And we've definitely been considering this with our team of experts, including our clinical experts. And what we know that peptides targeting sodium channels and antibodies targeting sodium channels that we're developing will not be addictive. Why? Because basically what we see sort of basic physiological effect, they will be numbing the peripheral nervous system. But this is where one of the interesting challenges also comes into play, because we don't want to numb the patient completely. We want to only reduce the abnormal transmission of chronic pain signals. We want to preserve the rest of the pain sensation, which is important for our physiological survival, acute pain specifically. And so this is where peptides and antibodies that we will be developing will be administered in doses that would fine-tune the pain, sensation to the level it only will be transmitting acute pain signals, but not chronic pain signals. That's where we're going. You can imagine like thermostat.
That's exactly what I'm...
Temperature range.
Yeah.
For each patient, this is again coming back to precision medicine. This is the future that we envision will be possible, to be able to suppress pain signals to the degree that would be comfortable for each individual patient. but not the numb patient completely. And we don't see any addictive potential as well, because basic effect of these sodium channel blockers is similar to lidocaine, which people use like lidocaine patch, for example, right? It's a numbing effect, like local anesthetic, basically. Or people who go to the dentist office, right? Similar, you have numbing for a few hours, but you don't have any addiction to it. You don't necessarily get numbed again. And at the physiological level, this is the actual response that we expecting.
Now, I think there's a fine line when it comes to that word addiction, because if you're not solving the problem itself, and if this is still considered a Band-Aid, and this Band-Aid only sticks for a certain amount of time, then there's going to be a repeat dosage. Is that not considered addiction, or
basically
is it just consistent treatment?
That's an important question, Kim, absolutely. Because it's just addiction of patients to opioids. What happens, opioids are very effective in suppressing pain signals, right? But they also affect our brain function. They created this cycle of addiction because there's a pleasure, basically, sensation and feedback in our brain.
Gotcha.
But they also provide.
And then you're ultimately needing higher and higher doses, and then the pills are too expensive, so they move to black tar heroin. I mean, like, that's the thing you don't want to have happen. Yes. You're going to give measured doses that last a finite amount of time that they're going to need more of until their pain gets resolved, but it won't require higher doses, right? Or they don't have that need or that itch to scratch, so to speak.
Precisely, because I was mentioning the already known, potential not to have side effects on the brain of our lead peptides. This is one of the key observations we already have. There should not be effect on the brain function, in addition to heart and skeletal muscle that I also mentioned.
Well, coming up right here on the Heart of Innovation, we're going to wrap things up. I'm curious about potential competition. If one university is focused on this, I'm wondering if they know of other research opportunities that are happening that could be competing. So stay with us.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. So we only have a few minutes left, and Kim had us on a little cliffhanger there. Vladimir, what competition? How do you guys protect your knowledge? And at some point, what are what's that next step? Do you partner with big pharma? Do you start your own company? Share with us your thoughts.
Yes, absolutely. We explore multiple different options. I mean, at this stage, we have patented our lead peptides for the University of California Innovation Access Office. And we've been approached by several different companies in the development of pain therapeutics. And so we're considering starting a company and also partnering with big pharma. Because ultimately, to get to the clinical trials, this is one definitely important challenge, but then to actually fund the clinical trials, that's another important challenge, because each clinical trial costs money, and it needs to be definitely considered sort of getting the funding from NIH. That's one potential opportunity, but also from industry, that's another opportunity.
Right, and then you have to balance the time between spending your time fundraising versus actually in the lab. And at that point, that's where it benefits you to start a company, find a CEO if it's not one of you, and that person becomes the chief fundraiser, goes out with your series A, B, C, D, gets those clinical trials going. And then at some point, big pharma goes, oh my gosh, this is going to really happen. And then you look for that exit strategy into a larger firm.
That's right. Because this is where we see, again, opportunity to ultimately develop even better peptides and antibodies, right, that we have right now over the next few years. But the key would be to bring them to clinical trial with definitely more funding from both NIH and industry.
So
this isn't something that's going to happen anytime soon. So anyone who's in pain today, I hate to say it, it's little, not even a glimmer of hope for any relief in the short term. What's the realistic timeline of bringing something like this to market?
Well, basically, we're looking at least a couple years of preclinical development, and then at least several years of clinical trials. So at least 5 years, roughly, time frame to be in clinic.
So Vladimir, we've got maybe a little over a minute left. What keeps you up at night, and what gets you out of bed in the morning?
Yes, very important. Also part of inspiration that we see every day opportunity to get better peptides and antibodies and more safe, ultimately, peptides and antibodies as future therapeutics to treat pain. And for us, inspiration, again, comes from all those patients who need this help right now. And so having the more effective therapeutics to treat chronic pain for them, that's our key inspiration and challenge.
Yeah, and that's also what keeps you up at night, isn't it?
Indeed.
Why can't we get this soonest, right?
Yes, indeed.
So if people want to reach out to you and follow you, they can follow you on Twitter. What's your Twitter handle?
It's VYY_SF.
Fantastic. Thank you so much for all your very important work you're doing. And thanks everyone for joining us here on the Heart of Innovation.
Thank you so much again for the opportunity.
And when you get that Nobel Prize, we're going to have you back on.
You've been listening to The Heart of Innovation with Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips. Our mission is to help patients live a better quality of life through comprehensive education, real-time support, and high-touch advocacy in partnership with thewaytomyheart.org and Take a Stand Against Amputation. Our purpose is to reduce the 1.5 million heart attacks and strokes and nearly 200,000 amputations annually. For more information regarding topics you've heard discussed on today's program, go to theheartofinnovation.org. That's theheartofinnovation.org. The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.